Hello, good morning. Welcome to Grand Rounds on this brisk winter day. We're really delighted to have Dr. Jenny Lin with us today, who is a professor of medicine in the Department of Medicine, Division of General Internal Medicine at the Icahn School of Medicine at Mount Sinai. Also, a really wonderful friend to the department and to many of our faculty, specifically related to her work in mentorship and women in medicine. And we've been delighted to have the collaboration of Dr. Lin with people like Amy Rosenberg as we try to foster even more our sense of mentorship within the department. Dr. Lin, following receiving a Westinghouse Science Award as a senior in high school, I don't know if I've met anyone else in person, Jenny, but then went on to Harvard, where she completed her BA and also her MD, and then stayed in the Harvard system at the BI Deaconess Medical Center, where she completed a primary care residency in internal medicine. Following that, she spent a couple of years still in Boston as junior faculty, and subsequent to that has been in the Sinai system for a number of years at this point. As with all accomplished people I know, Dr. Lin does a remarkable number of things in the course of a day and week and has done in her career. We're going to hear a lot today about her work related to cancer survivorship, but also apart from mentoring for folks to know, and in particular maybe for clinician educator track faculty or for residents thinking about that track as their career path, to understand the trajectory of her career as it relates to her research and her work in as a clinician educator. She's also had leadership within internal medicine and SGIM. She was the Mid-Atlantic region president and also chairs the cancer interest group for SIGM. Jenny, it was really a delight for me to review your CV, and we're really pleased to have you with us today, and welcome.
Thank you, everyone, for having me today. I'm not sure what to do after that introduction. The expectations aren't too high. But anyway, thank you so much, everyone, for having me here today. And please feel free at any time to just chime in or ask any questions. I don't want to think of this as a formal talk. If possible, I really prefer sort of more small group discussions in general. So really going to talk a little bit about some of the work that I've been doing and sort of get your thoughts and questions. So I have no conflicts of interest. I'm going to just go over the background of my talk, talk a little about comorbidities in cancer, and then cancer and comorbidities. And so this may look very repetitive and redundant, but I'm going to explain to you a little bit about why these are sort of different concepts. And then I'll wrap it up at the end with comorbidities and cancer again. So really quickly, and many of you probably already know this, but cancer is the second leading cause of death in the United States. Currently, just shy of heart disease in terms of causing death in the U.S. And you can see here again more recent data that cancer just is again shy of heart disease as a leading cause of death in the United States. This is just the last few years. And that the third most common cause of death, which is unintentional injuries, is less than 1/3 that of either cancer or heart disease. As you know, the most prevalent cancers in the United States are prostate for men and breast for women. Breast cancer accounts for about 30% of all new cancer cases among women, and prostate counts for about 20%. Second and third for both men and women are lung and colorectal, respectively. However, because breast cancer and prostate cancer are diagnosed often at early stages, they have a pretty long survival time, and so the leading cause of death still for cancer is lung for both men and women. And so you can see here just summarized, for causes of cancer as well as risks for cancer. I'm not going to go over that. But just really quickly, people know that there are genetic risks as well as environmental exposure risks and then behaviors. And then what about diabetes? This is a very common comorbidity that we see. It's probably a common disease that all of you at some point take care of in some venue or another. And so if you take a look at this data in the United States about how diabetes has progressed in the last 15, 20 years, you can see that, this is the most recent, that up to a third, maybe even half of the United States, at least geographically, has a diabetes prevalence rate of greater than 9%. So almost 1 in 10 adults have diabetes in some parts of the US. And so currently affects about 30 million people. Most of them are adults. About a quarter of adults over the age of 65 have diabetes. It is a much higher prevalence in Asians, Hispanics, and non-Hispanic Blacks. And it is projected to increase to 48 million, so another 18 million people in about 30 years by 2050. It is the seventh leading cause of death, and over a third of the US adult population have prediabetes, so are at risk for developing diabetes. In 2012, which is the latest data that I could find, the total direct and indirect estimated cost for diabetes care in this country was $245 billion. It's a huge amount. So that's just a really quick and dirty background on both cancer and diabetes, some of which I'm sure the majority of the people in this room already know. So what about comorbidities in cancer? And I'm going to focus here on diabetes. How does that influence cancer risk, so your risk for developing cancer, as well as cancer prognosis? So what we do know is that diabetes does increase cancer risk. It increases risk for most cancers, but not all. Specifically, it can increase the risk for breast cancer, colorectal, hepatocellular, and endometrial cancer, up to about 2 times. So if you have diabetes, you are more likely than someone who does not have diabetes to develop these cancers. But it does actually interestingly seem to be somewhat protective for prostate cancer risk. So having diabetes seems to lower your risk for prostate cancer, and it's not yet clear why. But when you look at this data, and this is pretty old data from well over 10 years ago, so it's been well established, large population cohort studies, you can see that the risk for breast cancer, the risk for breast cancer is here, really heavily weights this forest plot, but your overall risk for cancer among women is about 1.3, so 30% increased hazard ratio for developing cancer if you have diabetes. So diabetes seems to drive a cancer risk. In cancer for men, rather, it is equivocal, and that's primarily because the prostate cancer risk seems to be decreased. However, the risk for other cancers, non-Hodgkin lymphoma, certainly bladder, colorectal, pancreatic, hepatocellular, are all way over here above 1. So increases, as it does in women, risk for these cancers. So why? Why would diabetes possibly increase your risk for developing cancer? So lots of possible causes. One is that most diabetes in this country is type 2 diabetes, which is related to insulin resistance and then consequently hyperinsulinemia. There is a thought that insulin can directly stimulate mitosis in tumor cells, and it's been found. But insulin can also indirectly modulate circulating growth factors as well as binding proteins, and that can increase cell proliferation. Finally, insulin can also activate growth factor receptors, right? So there's insulin-like growth factor that we know about, and that can stimulate cell growth. So hyperinsulinemia, as a result of insulin resistance, can stimulate cancer growth because of these mechanisms. It can also cause increased steroids and peptide hormones, so it being diabetes, also results in often higher levels of steroid and peptide hormones. And so as a result of that, you have increased levels of leptin, and that increases endothelial cell growth as well as suppressing apoptosis. Increased steroid hormones also causes reduced levels of adiponectin, which then inhibits inflammation and cell growth. So if you have lower levels of adiponectin, you have higher levels of inflammation, higher levels of cell growth. Finally, diabetes, as we know, is somewhat pro-inflammatory, and it has been shown to have increased levels of IL-6 as well as TNF-alpha, and these we know can stimulate cell growth. And lastly, hyperglycemia itself may increase oxidative stress, and that in and of itself may drive cancer or tumor growth. My colleagues in endocrine, Emily Gallagher and Derek Leroy, did a really nice sort of review of this in 2015 and sort of have this really beautiful graph, many of which include, biochemical mechanisms that I don't know that much about, but you can actually see the hyperinsulinemia here with the hyperglycemia, the IL-6, IL-1, TNF-alpha, and sort of inflammatory markers, and then some of the topics that I'm not going to talk that much about, but the bioavailable estrogens. And so their main focus is looking at diabetes and breast cancer risk, and this, as we know, can increase breast cancer risk. So what about diabetes and cancer prognosis? So hopefully I've made a pretty convincing argument to you at this point that diabetes can increase your risk for developing cancer. But what if you have cancer and you happen to have diabetes? What does that do? How does that affect your cancer? So diabetes overall worsens your survival, which kind of makes sense because maybe because you have diabetes, you have heart disease, or you're at higher risk for stroke. But what we do know from these large population studies, and again, this data is like 10 years old, so it's not new, so it's pretty well established that cancer survivors who have diabetes have lower overall survival than cancer survivors who don't have diabetes, right? And it's about a 1.2 to 1.4 hazard ratio, so pretty significantly, a 40% increased risk of death if you have cancer and diabetes versus if you just had cancer alone. And this is pretty much for all cancers. And again, the study by Bethany Barone in JAMA from about 12 years ago now, showing a pretty significant increased risk for pretty much all cancers. But diabetes itself can also worsen cancer prognosis. So it worsens overall survival, but maybe that's the diabetes, driving heart disease. But it actually also worsens overall cancer survival, and it can do it in breast, colorectal, and prostate cancer. So I said diabetes decreases your risk for developing prostate cancer, but if you have prostate cancer and you also have diabetes, that actually worsens your risk quite a bit by a hazard ratio of 1.6 almost, so 60% increased risk. It also increases your risk for breast cancer recurrence. So when you think of early stage breast cancer is pretty curable, but if you have diabetes, you have a higher risk of having breast cancer recur. So why? Why could this possibly happen? So, some of the things we talked about earlier about how diabetes can increase your risk for developing cancer, but also, when you think about diabetes, unless it's very well controlled, you have periods of hyperglycemia. And we have found that hyperglycemia is associated with both more aggressive cancer presentation, but also decreased responses to chemotherapy, radiation therapy, and higher risk for complications after therapy. So survival and worsen cancer-specific survival since you're not responding to the therapies for your cancer. All right, so we've covered how comorbidities can affect cancer, and so now what about cancer and comorbidities, and what do I mean by that? So when you think about cancer now, cancer treatment has really become much more effective, and certainly with the very common cancers like breast cancer and prostate cancer, people survive for a long, long time, and often maybe are even cured from these cancers. So we have a growing number of cancer survivors who have multiple comorbidities. Cancer is a disease that happens as we age, so people pick up comorbidities as well. So lots of comorbidities. A quarter of all cancer survivors actually die from illnesses other than their cancer, and I'll show you some statistics about that. And then for breast and prostate cancer, again, the two most common cancers in the United States, also very low grade, tend to be indolent, can be cured. Heart disease is actually the primary cause of death among these cancer survivors. So they don't die from their cancer, they're actually dying from something else. And so why is this important? So let me go over the cover and tell you a little story. So this is kind of a busy slide. This takes a look at the last 30, 40 years and looks at causes of death in cancer survivors. And the way to read this is the green is if you have cancer and you die from a non-cancer cause. If the gray is dying from another cancer than your index cancer, the first cancer, and the black is dying from the cancer that you were originally diagnosed with, right? So you can see that over the last 40 years, the cause of cancer being your cause of death, if you're a cancer survivor, has gone down. And this is probably because treatments have gotten better. And as a result, consequently, the causes of death for a cancer survivor resulting from something other than cancer, certainly other than their original cancer, has gone up. And that's what's represented by this green bar. So in 1975 or whatever here, if you develop cancer, your likelihood of dying from your cancer is about 70%. Your likelihood of dying from another illness, not your cancer, is about 25, 30%. But way out here in 2010, just when this was last done, your risk of dying from your cancer, this is again all cancers, is about 50%, right? And your risk of dying from another cause, not cancer, is now about 30, 40%. The way this gets broken down here is the black here is these are all the different types of cancers. I know this is a really busy slide. These are all the different types of cancers. And these are people who die from their cancer. So the biggest purple bar, which you can see here, is representing lung cancer. So again, lung cancer is still pretty mortal. And although recently with immunologics, survival is getting better, but still, a very mortal cancer, and people who develop lung cancer tend to die from their lung cancer. Whereas in D, these are the people who develop cancer but don't die from their cancer. They're dying from another non-cancer cause. The biggest bars are blue, which is prostate, pink, which is breast. And you can see these have expanded over time. So breast and prostate cancers tend to die not from their cancer, but from another cause. And so,
I'll ask a question.
Yeah.
Since you encourage it.
Please.
I'm just curious, does DD include infectious diseases?
It includes,
thinking about diabetes.
It includes anything. It includes any cause of death that is not cancer. The little gray bar here are your second primary cancers, but we're not going to go into that. But yes, it can include any cause of death. And what we do know from epidemiologic studies is that the leading cause of death in breast and prostate cancer survivors, certainly over the last 5-10 years, is heart disease. So breast and prostate cancer survivors don't die from their cancer. They're really primarily dying from heart disease, of which, as we all know, diabetes is a major driver, as is hypertension. We'll talk about those. Even in lung cancer, just because I know lung cancer looked so terrible there, but I just want to, this is an analysis that we did just recently with the SEER data. We find that if you're diagnosed with an early stage cancer, and again, if you're thinking that we're going to be doing more and more lung cancer screening for those who are at high risk, we hope that we'll catch people at early stages. What we find is that up to a third, or here even, right, 50% of patients with lung cancer, if they can survive past the first 5 or 6 years with their lung cancer, are actually dying of other causes, right? And so this is what this is showing, is that if you're diagnosed with lung cancer and you're 75, if you can manage to survive another 5 or 6 years, you're not going to die from your lung cancer. You're actually going to die from, another non-cancer cause or cardiovascular disease, which makes up the vast majority here in the gray bar. And this is true for men and women, both. Right? So if you're diagnosed with lung cancer at an older age and you're diagnosed with early stage cancer, you're generally not going to die from your lung cancer. So all that brouhaha that I said about lung cancer, being a major cause of death, it is true, but there are caveats, right? And so if you're diagnosed at an older age, you tend to have other comorbidities. If you're diagnosed at a lower stage, you probably will end up dying from your comorbidities rather than from your cancer. And so this is a really big thing that I just want us to sort of think about, is a lot of cancer survivors end up not dying from their cancer. The other thing to know is that, cancer survivors overall report more comorbid illnesses in the general population. Maybe that's because, these other comorbidities or their risks for comorbidities also increase their risk for cancer. So obviously the biggest one is like smoking increases your risk for COPD, but also lung cancer. So they tend to run together. And then what we also know is that comorbidities really negatively impact cancer survivors' overall health and quality of life. They report worse physical health, worse social functioning in terms of mental health and depression, and an overall worse quality of life. And so I just want to talk about why I got interested in this. And so I'm going to just tell you one really quick anecdote. Because in medicine, why do we do what we do? We do what we do because of the clinical aspect, right? And so what I noticed a number of years back now is that I had, I'll talk about one particular patient in general, Mr. E, who had diabetes, and it was fabulous. He was controlled on just one medication, and he had an A1C somewhere between 6.8 and 7.5. He worked as a sort of temporary cook, and then he got prostate cancer. And prostate cancer wasn't too bad. It wasn't great. It was a Gleason 7 or 8. And so he had to get seed implants, and he had some urinary issues as a result. And he had to be on Lupron, and that definitely sort of may have tipped him over in terms of his diabetes management. But during the time that he was getting treated, and even after, his A1C never came down again to below 8. He is now 8 years, 10 years almost now, from his diagnosis. And I still cannot get his A1C back into a good range below 8, and this now on insulin plus other medications. And so, during that time period where he was getting treated for his cancer and his sugars were all over the place, and I was really trying to struggle to try and help him get them better, I just, kept thinking, like, what happened, right? His diabetes used to be great and in great control, and so something happened, and it may have been related to the cancer treatment, but he's been out of cancer treatment for at least 5 years now, so I don't think the Lupron's still working in his system. So what is it that, sort of switched around how he's thinking or how he's eating so that his diabetes is no longer in control? And so that's sort of the premise of this study that I'm going to talk about. So, what comorbidities, as we've talked about, may negatively affect cancer survivorship, right? Increases your risk for cancer, increases your worse cancer prognosis, both overall and cancer specific. I thought, or I was starting to think, that maybe cancer and developing cancer may affect how you manage your chronic illnesses. And it can worsen how you manage your behavior. So much of the chronic illnesses that we take care of, certainly in primary care, hypertension, diabetes, everybody here takes care of it too, but is about managing yourself, right? Not eating, that cheesecake when it's there in front of you, or, trying to be really careful about, how much salt you're taking in. And so, is it the worry about the cancer? Does that somehow change how you then think about your other illnesses? And then, as we know, poor self-management behaviors like medication or diet adherence can lead to poor disease control. And so this was the main crux of the question, is if cancer has a negative effect on self-management behaviors for comorbid illnesses. And I think I've tried to make the argument now that certainly for early stage cancers and for common cancers like breast and prostate, comorbidities are really important, because these cancer survivors are actually not dying from their cancer, they're dying from their comorbidities. We do worry that cancer survivor morbidity and mortality can increase because of poor control of comorbid illnesses. So this is this study, which is the impact of cancer on adherence and diabetes, and I'll tell you really briefly about it. The study objective was to assess the effect of a new diagnosis of early stage breast, prostate, colorectal, or lung cancer on self-management behaviors for patients with diabetes. So what we did was we, at baseline, enrolled diabetes patients with a new diagnosis of cancer. We had to do a fair bit of chart review to do this. And then we would enroll a matched control patient, so matched by age and gender and A1C baseline. And then we assessed their A1C, their medication adherence. We really asked questions about what their beliefs were and their thoughts about their cancer, as well as their diabetes and their emotions around these illnesses. And then we followed them for a year to see, how these may have changed, comparing the cancer patients with the non-cancer patients, everybody with diabetes. So this is this cohort, and again, this study has ended, so we are still doing some data analysis on it. The ages are similar, obviously, because we matched on age, and the genders. The education levels were a little bit different, as well as the income levels. The cancer patients had generally, these are the non-cancer patients, so the diabetes-only patients had generally lower education levels, as well as were poorer. The partnership status was the same. We did not match on race ethnicity, so there's a little bit of difference. And then if you see among the cancer patients, the majority, again, were breast or prostate, and we did have some early stage colorectal and lung cancer patients in this cohort. So what do we know? So we did find that at baseline, the patients with cancer versus the patients without cancer were a little bit different in terms of what they report, in terms of how they manage their diabetes. So non-cancer patients reported checking their sugars, a little bit more often than the patients with cancer. But the number of days of exercise per week, the number of days they reported eating healthfully, and the number of days that they checked their feet were more or less the same. It's really sad here. What I thought was that, nobody's exercising, but we kind of all know that, but no one's exercising. And what you see here is this is medication adherence. So this is their adherence to their diabetes medicine. That's what we're interested in. And again, I'm in primary care, so my outcomes are all primary care based and outcomes that I take care of. So, are you taking your medicines? And they're not oncologic based, even though the studies are funded by the NCI and they're in cancer survivors. The outcomes I'm interested in are all outcomes that I see clinically. And what you do see is that their diabetes medication adherence in the patients with diabetes and cancer versus those without cancer is a little bit different at 3 months. And this kind of makes sense because 3 months this is 3 to 6 months post-diagnosis. We enrolled them within 3 months after diagnosis. So this 3 month here means about 6 months on average after your diagnosis. A lot of the cancer patients are still in treatment. So they're not thinking about their diabetes medicines as much. Whereas the non-cancer patients, obviously, they're just doing their own thing. They have their diabetes, and their adherence rate is not too bad. It's not great, but it's pretty good. Almost 80% adherent. We consider that adherent in the medical adherence literature, but a little bit different. But by 12 months, it's about the same. And non-cancer patients have weaned off, but that may be just a fluke, and it's certainly not statistically significantly different. So if you look at their behaviors over time, this is sort of looking at some of that data I showed at the beginning, but just sort of longitudinally, you can see checking your sugars as recommended higher in the patients without cancer than the patients with cancer, but then over time sort of evening out, and again, not really statistically significant by the 12-month period. The number of days that they report eating a high-fat diet, so you want to be lower on this scale, again, about the same, right, for both groups, although maybe splaying out a little here at 12 months with the diabetes-only patients sort of saying they're not eating it as often, and the cancer patients trending up a little bit. But again, that's a really non-significant trend. The number of days of physical activity per week, again, not too bad here. And so this is, 3-4 days, and again, about the same. And the trend is similar, actually, for the two groups. And then the number of days that they check their feet per week, again, this is different between the two groups. So people aren't checking their feet that often, and certainly people with cancer just aren't really looking at their feet. When we look at cancer patients alone, what we see is that one of the questions we ask them is, how much does cancer affect your life? There's a scale called the impact of event scale, which sort of gets a little bit at sort of possible PTSD-ish type symptoms, and can be used to make you think about risk for post-traumatic stress disorder related to cancer. And so what we see at baseline is that over a third of patients who have a newly diagnosed cancer actually report pretty high cancer-related stress scores, right? It's suggestive of possibly having PTSD type symptoms related to their cancer. So 38% have the score that's pretty high. And again, the questions ask, how often do you get intrusive thoughts? So, thoughts about your cancer when you didn't want them to come in, or how often do you do sort of these behaviors that try to make you avoid thinking about cancer. What you see here is that the cancer-related stress numbers don't change that much between baseline and 3 months of enrollment, so they're still about the same. It seems to go down a little bit, but again, this is a pretty small sample, and so it doesn't look statistically significant. But what we did find is that if you have these avoidant behaviors, thoughts, or intrusive thoughts, you are much less likely to exercise. So your mean number of days reporting exercise, and these are all just for the cancer patients, obviously. So if you are more affected by your cancer, trying to avoid thinking about cancer or having lots of intrusive thoughts about your cancer, you are less likely compared to the cancer patients who don't have these thoughts to exercise. So cancer-related stress can definitely affect your ability to self-manage. And then I'm going to turn a little bit and talk about illness beliefs. So these are behaviors, and so how do beliefs possibly relate to behaviors? So in the behaviors literature, what we know is that your belief about your illness, so your belief about your diabetes and how well you can control it, or how controllable it is, or how concerned you are about it, can often be associated with the behavior. And that makes sense. What we did here was we actually took a look to see how your belief about one illness, how your belief about your cancer may then impact your behaviors for your diabetes, right? So that was the new twist here. Most of the times people look at your beliefs about one illness and how it affects that illness and your behaviors for that illness. But here we're looking at your beliefs about a a separate illness and how it might affect your behaviors for that that first disease. So what I want to show here is that when you look at these beliefs about their illness, the beliefs are actually quite different. People think very differently about their cancer versus diabetes. And maybe this is kind of like, duh, but no one's really shown that before. So how much does your illness affect your life? Cancer affects your illness. So the higher scores mean it affects it more. How long do you think your illness will continue? So most people, the median score for diabetes, put it at 10, meaning that it's a chronic disease. It's going to continue forever. Whereas the median score for cancer was 0. A lot of people feel like their cancer is cured, right? And maybe that's a good thing, but they don't think they have cancer anymore. And maybe that's also the way that the oncologist or the urologist talk to them. You're cured, you're done, right? And we know that that is true, hopefully for the most part, but cancer also does come back, and people either don't want to think about that or are really believing that they're totally done. How much control do you have over your illness? So people feel they have more control over their diabetes and their cancer, and that's probably good because that's probably true for the most part. People are pretty confident in how they think treatment will help. How much does your illness affect you emotionally? So, cancer really affects people's emotions much more than diabetes. Maybe this is because this is a new diagnosis of cancer, so it's recent, and you've had diabetes forever and then some. I don't have data for another study, but I will tell you just now, sort of off the record, I guess, that's not published, that in another study, and we'll talk about it later, with people who are 5 or 6 years out from their cancer, when you ask them these questions about their cancer and their diabetes, the cancer still affects them more. But in this population, these are newly diagnosed, so it sort of makes sense. What we did find, though, and this is sort of what I alluded to earlier, is that if you have a higher sense of control over your cancer, you are more likely to actually check your sugars more often. So this is the control. And it goes both ways for checking your sugars and as recommended. If you feel like cancer has a big impact on your life, you are less likely to check your sugars. You're also less likely to exercise. And that kind of makes sense from that data I showed you earlier with just the cancer population. And those who have higher intrusive thoughts, are less likely to exercise. So if cancer impacts you more, so again, here it is. If you have more control over your cancer, so this is just in the cancer survivor group, you're more likely to check your finger sticks more. If you feel that cancer has less of an impact on your life, you're more likely also to check your finger sticks more as well as exercise more. So your beliefs about one illness can potentially affect, and is certainly associated with, can't talk about causality because we really don't know, but it's definitely associated with your behaviors for another illness. I want to talk briefly about a study that's currently ongoing that looks specifically at breast cancer and diabetes, and in this particular one, we're looking at cognition. So really quickly, older breast cancer survivors are more likely to have more comorbidities like diabetes. Up to 70% of cancer survivors may experience cancer or treatment-related cognitive dysfunction, something like chemo brain, which can happen during and after treatment and persist. And then, as we know, older adults are at higher risk for cognitive decline. So cognitive dysfunction, right? And diabetes also can contribute to cognitive dysfunction. When you think about cognitive dysfunction in diabetes and breast cancer, they generally affect these domains of memory, attention, communication, and executive functioning, so your ability to organize your day or organize your life. And then breast cancer and its treatment, diabetes independently, and older age are all independently associated with cognitive dysfunction. So we recruited a group of women who are older, have breast cancer, and also diabetes, so a triple hit, cognition, to assess whether or not cognition influences or impacts diabetes and cancer illness beliefs, and then diabetes self-management. So this study is ongoing. This is a conceptual model, which is probably a little bit busy, but again, just sort of giving you a sense that cancer and age and diabetes can affect cognition, how cognition may then affect your cancer beliefs or your diabetes beliefs, how these two then interact to affect your diabetes management and then your diabetes outcomes. So preliminarily, we've enrolled 113 women across 3 sites. This is the sort of social demographics among them. And they're a bit older, again, because we're targeting older women. So we're not recruiting younger breast cancer survivors. They all have diabetes. There's some differences between the sites, as you can probably imagine. The Mount Sinai site has, a larger proportion of minorities as well as Latinas, and a somewhat higher majority of people with lower education and income. And so what we looked at was looking at these cognition effects and found that there are some significant differences in delayed and immediate recall. So again, this is memory as well as executive function by race, ethnicity, and education. So not unexpectedly, if you have lower education, you're probably more likely to have lower cognition. And what we found is that cognition can actually affect self-management behavior. So if you have these are statistically significant, just showing you the ones that are. If you have lower cognition, so lower memory, or lower executive function, you actually report eating healthy more days a week than if you have normal or high cognition. But you report exercising far fewer days. And that cognition and cognitive sort of impairment is related to illness beliefs. So if you have a cognitive impairment, you are more likely to believe that your illness is cyclical or episodic, meaning that it's not chronic, and you are less likely to believe that treatment can help control your illness. So this is sort of summarized in this slide, that patients with lower cognition were more likely to be of Hispanic origin, have lower income, less high school attainment. So that makes sense. And that participants with lower cognition, particularly those with lower attention or working memory, as well as executive function, reported fewer days of exercise per week, but more days of healthy eating. They also felt that their diabetes was less controllable, and they also felt that diabetes and cancer, that they felt diabetes was, coming and going rather than chronic disease, and they felt that way also about their cancer. Another study I want to tell you about just really quickly, and certainly if anybody has patients that might be eligible for these studies, let me know, because we are still actively recruiting for both of these, is a study entitled CHAMPS, which is a study looking at cancer and hypertension, attitudes and management among prostate cancer survivors and their partners. And so really quickly, about 50% of prostate cancer survivors have comorbid hypertension. It's very prevalent. It's associated with substantial morbidity and mortality because it is the major risk for heart disease, which is the major cause of death among prostate cancer survivors. And we do know that spousal or informal caregiver involvement can really improve clinical outcomes in non-cancer patients. In patients with hypertension or cardiac disease, having a spouse or a caregiver, which can be like a relative or a child, can really help improve outcomes. And then we also know in cancer patients, having a spouse or a caregiver involved improves cancer outcomes. But we don't know whether or not that improves comorbid management outcomes in cancer survivors. So we're just combining these two really. So this is a study, which is an American Cancer Society sponsored study, to assess the effect of caregivers' beliefs about prostate cancer and hypertension on their behaviors, so the caregivers' behaviors, to support hypertension self-management behaviors among their spouses or cancer patient survivor. And then we also are looking at the cancer patient, the cancer survivor, and looking at his beliefs about his illness, both his hypertension and his prostate cancer, and how he's managing it. So this is the model really quickly, a little bit busy, but you can see there it's a dyadic study with a cancer survivor and a caregiver, and then we are looking at their relationship and asking about that too, because maybe you don't want to do what your spouse says because you just want to spite them because you don't like them anymore, or maybe you do what they say because you really believe in them even if you don't like them, or both. And then we're looking at these behaviors. We're looking at the cancer survivors' behaviors in terms of diet and exercise and blood pressure monitoring, and we're looking at the caregivers' behaviors to support self-management. So far, the study has recruited 127 people. We are doing dyadic study. We are doing a primarily dyadic study, but we are also including some patients who either report being in a relationship, but their spouse didn't want to participate, as well as those who didn't. So we can compare really how spousal support is impacting hypertension management. Again, this is the general overall demographics. The survivors tend to be a little older than their caregivers, and the racial ethnic breakdown is pretty similar. This is what was interesting. So again, those questions about illness beliefs, and so we asked them about hypertension, and we asked them for the survivors and the caregivers. So we asked the caregivers, how much do you think hypertension affects your spouses or your loved ones' life, right, and on and on. And interestingly, even though these numbers look pretty similar, when you look at these kappas, because these are just the median scores, but when you look at actually the pairs and the dyads, they actually don't match up. So these kappas are pretty low, meaning there is not a lot of agreement between the cancer survivor and the caregiver, except for this particular question about how hypertension affects their life. Whereas with cancer, there's a little bit more agreement overall. And if you look at these numbers, which is hard to do, I didn't want to put it on one big messy slide, people are still more concerned about their prostate cancer, and they experience more symptoms, and the caregivers support this, than from hypertension. So the summary here is that cancer survivors and caregivers report greater concern and emotional impact of prostate cancer compared to hypertension, and less controllability of prostate cancer compared to hypertension. This is overall, but that generally survivors and caregivers had poor agreement on most domains about the hypertension controllability and timeline, but that survivors and caregivers had greater congruency, so greater agreement on beliefs about how long they thought prostate cancer would continue and how well they feel they understand prostate cancer. I realize I'm probably running out of time. Do I have another?
Okay.
Okay. Really, really quickly, I'm going to come back to comorbidities and cancer, and then I'll be done. So really, this part is looking at diabetes and cancer outcomes, and specifically, I'm going to talk about some data that I've done looking at diabetes medications and cancer outcomes. I'm going to look at metformin. So, because it's very common. Metformin has been shown to actually be associated with a decreased risk for developing cancer. All cancer incidents, a pooled ratio of 0.67, which is pretty darn good. A 30% risk reduction for developing cancer if you're on metformin, and this is pretty much across all cancers. Hepatocellular always amazes me. It's like 0.2, like that's a huge risk reduction. This is that study. Again, this is about 8 years old now, but across all cancers, metformin seems to decrease your risk for developing cancer. Metformin also decreases your risk from dying from cancer. So when you compare metformin to other either oral hypoglycemic agents or insulin, in diabetes patients, which already are at risk for having worse cancer prognosis, if you're on metformin, it actually decreases your risk compared to if you're on or an oral sulfonylurea or another medication for your diabetes. So these are all diabetes patients with cancer. If you're on metformin, you do better. And so why? Metformin can reduce insulin resistance. It can reduce circulating insulin levels, and we talked earlier about how insulin may drive cancer proliferation and tumor growth. And so you can decrease your activation of the insulin-like growth factor. It can also act directly on tumor cells by altering their intracellular pathways. So it activates the AMP activated protein kinase, which then downregulates your protein synthesis as well as cholesterol and glycogen. We did I'm just going to go through this quickly. We did a study looking at metformin in lung cancer. We looked at patients diagnosed with stage 4 lung cancer. So that's a pretty mortal disease. We used the Serum Medicare database, and we looked at all lung cancer cases through 2010. So this was the inclusion criteria, looking at this very large database. We excluded people with CKD or end-stage renal disease or who weren't on medications for diabetes, mostly because they would never have had a chance to be on metformin, so they weren't excluded on this because you can't compare the groups then. And then these were the methods, which are a little bit busy, but a univariate analysis and a propensity score analysis to sort of match the groups a little bit better, and then these survival curves. This is the population of cancer survivors in this group of Serum Medicare. There's actually not cancer survivors because these are stage 4 cancer patients, so they've all deceased. But again, large group, when we match them, you can see here, this is the p-value. When you match the groups, they are very similarly matched across all sort of domains of comorbidity and medication use. When we do the matching, it actually does work. And then just as the crux, if you have stage 4 lung cancer and you have diabetes, if you are on metformin, you have a longer survival time than if you're not on metformin. Survival time really does stink, to be honest, because it's only 5 months for your median survival time versus 3 months. But that is still something. It's a 2-month difference in median survival for stage 4 lung cancer, and this was about 5 years ago. If you stratify it by groups, the group that received chemotherapy versus those who didn't. If you received chemotherapy, you do better. And now with immunologics, this may even be better, but we don't have that data. But if you're in the metformin group, you still get a little bit of extra added time than if you're not in the metformin group. And similarly, well, if you don't receive chemotherapy, you're survival is terrible. But again, if you're in the metformin group versus the non-metformin group, you survive a little bit longer. And then this is for people who are treated with insulin, so metformin plus insulin versus people who aren't on insulin. And insulin tends to increase your mortality. So really quickly, when you do Cox, so that's a Kaplan-Meier, which is an unadjusted analysis. So the Cox regression is an adjusted analysis, adjusting for lots of other potential covariates that might affect morbidity. But essentially, the takeaway message is that metformin seems to reduce your risk for death in stage 4 lung cancer by about 20% overall. And this is sort of, when you do secondary analysis, you look at all these subgroups. But again, the overall take home is about 0.8. So the conclusion there is stage 4 lung cancer patients with pre-existing diabetes, metformin compared to other diabetes medications was significantly associated with better survival and may potentially ameliorate the oncogenic effects of insulin was our conclusion. So again, thank you for your time. I could not have done any of this without lots and lots and lots and lots of help from mentors and colleagues, as well as all of the really fabulous students and research assistants and project managers that I work with, and I'll take any questions.
Yeah, this is more, I just wondered if you could comment. Health and literacy is such a important part of our challenge. And I'm just interested in the CHAMP study to see for both patient and spouses report about how they understood the disease, hypertension as well as malignancy. I think we're 10 across the board. I just wonder if you could comment on that.
Yeah, so again, the question asks, how well do you understand your illness? Rating from a scale of 0 to 10. And so people seem to think that and feel like they understand their illnesses pretty well. We didn't do well, actually that's not true, because I think we probably did. They don't have the data in there, a formal sort of health literacy assessment. But it seems like in that study at least, people do feel like they understand their illnesses pretty well. Both the spouse and the cancer survivor feel like they understand both their hypertension pretty well. That's on a 0 to 10 scale, as well as their cancer.
Can you let the West person go?
Oh, sure.
Yeah, thank you.
Should I go? Hi, Dr. Lynn, this is Tamara Goldberg downtown. Thank you for your wonderful talk. My question is regarding the illness beliefs that you talked about. And within the diabetes world, there's sort of increasing evidence that screening for diabetes distress can identify patients with worse outcomes in terms of their diabetes. And I didn't know if you had two parts to my question. One, are there any recommendations you have in terms of screening using a tool to assess diabetes distress among our patients who are cancer survivors and have diabetes? And two, is there any recommendations you have in terms of outcome once you've identified these illness beliefs or distress among these patients?
I think those are both really excellent questions. We don't have anything that we use sort of regularly as a screening tool for distress related to diabetes. The impact of event scale, which is what we're using in the research study, does ask about cancer, but we actually didn't ask about diabetes. And you're making me think maybe we should ask about diabetes, because perhaps diabetes is stressful for patients. Regarding your second question about how to address it, it's really tough. I don't know if I have a great answer about that. There are definitely patients, certainly I'm thinking of one particular patient of mine who has had diabetes for 5 or 8 years and still comes in so resentful, so angry about her diabetes, and that she can't eat her Snickers or does, and is then feeling guilty. So I don't have a great answer for how we can reduce the distress. I think a lot of the things with illness beliefs is sort of first even recognizing that people have certain beliefs about their illness and knowing what they are, and then addressing any misconceptions. So for example, if you have a patient who has diabetes, this has not to do with distress, but they think it's episodic. They think they only have diabetes because they're eating sugar. That may be a good illness belief to address and redress for them. So I think some of the illness belief questions can help only if you know that they have the belief. And we often don't, because in clinical care, I have to say, I honestly don't actually ask those questions. They're in the research study, but I think one of the applications in the future is to think about how can we ask these questions or get a better understanding of where our patients are coming from And then with the distress issue, how can we support them better so that they can feel more motivated and more self-activated to manage those illnesses?
Thank you for a very complicated, actually, discussion and put it in a very clear way. I have two questions. One is, what was the total pool of subjects you looked at? In other words, what was dropout rate, people who didn't want to be part of a study, and what was actually, if any, dropout rate? Because that also can influence beliefs, understanding, and outcomes.
Absolutely. So the cancer and hypertension study, which is this one, and this other one, which is the breast cancer study, are still ongoing. So I don't actually have data for that in terms of overall and dropout. This study, which I talked about earlier, which is the one that's closed already, had a total pool, hold on, let me see, of about 170 patients. I think our dropout rate, and I have to go back and look, but I think we had a less than 20% dropout. Able to retain patients all the way through the 12 months. Obviously, people drop out. I do remember when looking at the data, we had the biggest dropout, or the biggest sort of missings, at 9 months, but we managed to capture them again by 12 months. So it certainly was a reasonable cohort. It wasn't very large. Again, this is 170 some patients total. And when we were looking just at the cancer patients, it was 73 patients, so it's not a huge sample size. So some of the associations may have been non-significant because we just weren't powered to find it. But the dropout rate for this particular study, because this one is closed, wasn't too bad. It was less than 20% that I do know.
The other question I have is and it's not looked at in any place that I can find, and that is diabetes goes with obesity. Obesity confers sleep disorders. And sleep disorders themselves then feed into hypertension, cardiovascular mortality, et cetera, et cetera, et cetera. So I'm wondering whether or not you're looking at sleep disorder as a component of contributing factors to outcomes. Clearly, when we don't sleep enough, we're mean, we feel irritable. So we don't have any other illnesses. So when you add these illnesses, which are made worse by sleep disorder, so can you make a comment?
I think that's a great suggestion. We haven't looked specifically at sleep, except for in the breast cancer study. We do ask about sleep because it is a common side effect of breast cancer treatment, but we haven't specifically analyzed on that yet. But we haven't sort of overall asked about sleep. And in this particular study, this one that's closed, I don't think we looked at sleep, but it's definitely a great. But we do get their BMI, so we have a sense of sort of what proportion are morbidly obese versus mildly, whatever,
Another question, Dr.
Yes.
Hi, this is Valeria, I'm one of the chief presidents. I wanted to ask you regarding the study comparing patients with cancer and diabetes and diabetes without cancer. Is there any difference in their follow-up or how closely they were being checked by their physicians? Just wondering if there was like a difference that will make the patients with cancer and diabetes be more controlled because they are followed up more closely than those with just diabetes will most likely not show up to their appointments. If you have any data regarding that.
I don't have that, although we can definitely go back and look at that since they were seen here. So I can definitely, take a look and pull the data for, how often they were scheduled for visits or making visits. I think the issue for the cancer patients with diabetes is that many times they don't actually have a lot of diabetes care during their active cancer treatment because the oncologist doesn't necessarily want to manage their diabetes or forgets about it. And the patient, like you said, is very busy with all these oncological appointments that they don't actually make it to their endocrinologist or their primary care for follow-up and for visit just to manage the diabetes. So there is that. You're absolutely right that they do have more attention to them and that may help them manage their diabetes better. What I didn't show because it was a null result is that the A1C, again, in this population, the baseline A1Cs are very similar because we matched on them, and that the A1Cs actually didn't change that much over time between the two groups. So they were not statistically significant. We had hypothesized that the cancer patients would have worsening A1C because they were on treatment and they may even be getting steroids, but they actually didn't have significantly different A1Cs with the diabetes group. Now, maybe the diabetes group, as you see here, are a little bit poorer, have less education, so maybe their diabetes also wasn't particularly well managed over the course of the year. But it's a reasonable sample size, so I can't say that that's true for everybody. But on average, there was not a significant difference in the A1C trends between the two groups over time.
Jenny and Sean and Billy, thank you for a great talk. So I want to ask you to change your role a little bit. If you can speak for a minute about your role as the fellowship director for the General Internal Medicine Fellowship, just so we can advertise your program for educators.
That's so nice. Well, thank you. We do have a 2-year Gen Med fellowship program. If anybody's interested in doing research, it does not have to be on cancer. Just has to be on something related. Well, actually, our fellowship is cancer prevention control, so it doesn't have to be on cancer control, but it could be on cancer prevention, which if you do internal medicine, you're interested in thinking about diet or exercise or smoking cessation, anything that could possibly increase your risk for cancer, alcohol, and trying to think about ways of addressing that, or cancer screening. We do have a 2-year research fellowship. We are actively looking for fellows for our next class starting this fall. So thank you, John, for that plug. So if people are interested and know people who are interested in doing 2 years of research with us, let me know. Thanks.
Hi, thank you for the talk. Appreciate it. In one of your slides, there's a PTSD of almost 30%.
Yes.
Who's doing something around the country about that? It's just like with that number, I mean, one would wonder who's treating that.
Yeah.
Because mental help that we're getting is just almost insistence as big as out. So, any thoughts?
Yeah, I mean, I think a number of cancer practices do have some standardized way of screening for cancer-related distress, and some of the comprehensive cancer centers do have like an in-house either social worker or psychiatrist to help people with that. So it sort of depends on the practice. So I know, for example, at Dubin, they do have that. But that's not necessarily true across all the different cancers. And I think your point is well taken that, we do have a number of patients who have cancer, who have a fairly high degree of cancer-related distress. And how is that being addressed? Right? Is that being addressed by the oncologist or the oncology team? Is that going to be addressed somehow by the primary care physician or whoever else is taking care of that patient? It's not systematized. In oncology, it's a little bit more systematized in some practices, but not standard.
Because one would think that with the growth of the disease population that is expected, at one point there will not be enough oncologists to address PTSD 30%. So it will fall necessarily care. Here's a good opportunity also to see what we can do to train people.
Yeah, I absolutely agree. Knock on wood, I have a grant going in, being reviewed next month, looking specifically at that.
We might involve some patients.
Thanks.
Jenny, thank you.
Thank you
very
so much.